teach them to push it all the way flush. And then I need a helper to hold the leg for me, just so it doesn't push away. So then you put it all the way flush, put it right dead center. Okay, and when there's a pin lock situation, I'll show you what to do with the pin lock. Then you come out with one hand, keeping it flush with the inside hand. And then both hands can roll it right on.
That's
That's nice.
in our search.
Nice.
It needs to be used.
Okay. All right. That's a liner. Where's the, oh, this was the pin lock. Oh, doy. All right, so the key about the pin lock that I didn't show you is the pin is coming directly straight out. That's a sealant. That won't help them on this one. So imagine a pin sticking straight out of this thing. Think of the pin as a projection of their femur if they're an AK, or their tibia if they're a BK. And you want to line that pin up in direct projection from the tibia. So you don't want the pin sticking up, out, this way, under, right? You want it straight. And it's one of the hardest things for amputees to get. It's pretty easy. Well, I shouldn't say that. When I was a new prosthetist, a new PT, working with amputees, I would put it on, thank you. I'd put it on, and let me do it where it's off skew. And be like, oh, whoops, pin's coming out that way. And I'd always sit there and go, okay, where's the tibia? Pin's out that way. Nope, that's not good. Let's take it off. Reposition, right? Move it, roll it back on. Where's the tibia? Where's the pin? Okay? The reason being, if you have the pin askew, and then you go into a lock that is vertical, now it might grab that pin at some point, but then it's going to pull on the distal residual tissues as you slide in, right? Which doesn't feel good, okay? So you want it to be in line. Oops. And if it's not in line, sometimes, usually, you won't be able to click in at all if it's not lined up correctly, okay? All right, I have only clips to use for ace bandage. Know that you want to use tape, not clips, on a real client, okay? I'll need a helper again. So for ace wrapping a BK, this is Bob Gailey's illustration of how to wrap a limb. It is not hard and fast. I have to follow every single step. The key things that you need to know about ace wrapping a limb. And then you can ad lib as you go. If you know the key things and you know how to do a circular wrap with no tension, and then a lot of diagonal wraps, right? So you guys know fishbone pattern, herringbone pattern? Figure eight-ish, yeah, okay. So we want to avoid placing any distraction or tensile forces on the incision, okay? We'll talk about that as in wrapping. You don't want to be pulling that incision open, basically, okay? Distal pressure, always greater than proximal pressure. So we start tight and loosen up as we go up the limb. Tension is applied only during the oblique turns. Never apply tension in a circular turn, that's a tourniquet. Okay. Figure eight, thank you. Word finding difficulties. Had a stroke or something. Avoid wrinkles in the material. Okay, wrinkles become areas of localized pressure, and that can cause breakdown. Use tape, not metal clips, to secure. All skin should be covered by the wrap. All skin. And you should try to have equal layers of wrap on the medial and lateral edges of the distal residuum. Okay? And that's so that you're not pushing harder medially and then squishing all of the swelling out laterally. You have equal pressure distally all the way around, and then pushing the edema up back to the watershed area of the body. Okay? If symptoms arise after wrapping, I'm tingling, I feel like my foot is falling asleep, even the phantom foot, okay? It feels too tight in general, okay? Let's check it. So when you have it wrapped, and I'll show you this, you want to be able to fairly easily slide a finger up underneath the wrap. It shouldn't be like, Right? Pry it away. Reapply every 4 hours. Yeah, right. It's more like every hour with Ace Wrap. It just unravels. They're in a small bed with sheets and blankets over them. They're moving around in the bed. It just unravels. It's horrible. Okay. All right, and then we'll go into tuba grip. So focus more on this than this. If you're still not confident with yourself, just following this, then go to this. I learned this way. But then I had a lot of very frustrated students that were taking way too long on something that you guys have enough clinical skill at this point to do a good wrap using common sense. Okay? So for BKs, you're going to use 3-inch, right? 3-inch. Sorry. Small ones this side. And I think these are 6-inch. Something 5 or 6-inch for AKs. Okay? You'll generally need 3 of the big ones for your AKs, and generally 2 of the smaller ones for your BKs. You'll hold the limb. This one, unlike the foot AFO Ace Wrap method, you definitely want to start with a proximal secure wrap, and you go above the knee for that. All right? So we're going to start up here. Oh, by the way, on this model, this is the kneecap, the little white tape. And these are actually blanks in here, so they're foam blanks that were pulled from the limbs of actual amputees. So you can actually feel tibial plateaus and stuff. This is an actual femur with, yeah, a lot of padding. These are PVC limbs, by the way, that I created myself.
No.
All right, so we're going to start with our anchor wrap above the knee. Who can time me? Someone time me.
You're at 7 minutes on the video.
Okay, but starting now, all right? Someone got it? All right, so I'm going to come down. I've got my anchor. I'm going to go ahead and go around and come down. So I'm doing my first descending wrap. This is all loose, by the way, right? My anchor is loose. I'm going to come down and capture this, let's call it a medial edge of the limb. So this guy's a lefty, okay? Now I'm going to come up below the knee. I've got this good and tight because that's an oblique turn. Okay, so you can give your tension on the oblique turn. Come below the knee, kneecap. Come down. And again, apply a good bit of tension there. I have a little hole. Those of you on this side can see there's a little gap there. Well, I'm going to get it with that turn. And now I'm running out of my face bandage, right? So then we would tape, not clip, on the real limb. Do a couple tapes so it doesn't bunch up and wrinkle. And then we're going to start our next wrap. We don't need an anchor. We'll go in the same direction you were going. Again, start with less pressure because it is your anchor, even though it's a diagonal anchor. Now I'm going to get my second layer on that medial edge. No, lateral. Can't remember what I said. Lateral. Come around again. Come and capture this other edge. Now the thing that's tricky about these limbs is these are limbs that have already atrophied. So when you have a more cylindrical, broad, even bulbous distal limb, you have a lot more surface area to cover here. Normally you're not going to completely cover the distal residuum with 1 and 1. Okay, it's usually going to be like a little gap there in the middle that you'll have to come back and get with another pass. But now I'm going to go for my third layer. Bring it around. Come and capture this one. Give it some tension. Third layer, medial and lateral. We might get another. So if you're 1 off, I'd say as far as layers go, that's fine. But you don't want to have like 2 and 4. 3 and 4 or 4 and 5 is okay, right? And then we would clip it. Let's just see. Let's move our guy around in bed. Oh, there you go. Already. All right, I don't know where he was, so we're just going to clip it. We're going to move our guy in bed and see how easy it is. These clips suck. Whatever. Go ahead and move him. He's sliding around in bed. And we'll give it some tension. There's no sheets there to rip off his. It's not helping. It's not working. they fall off. Okay? So that's the ACE-RAP method, or
That was about 2 minutes and 4.
a
yeah. 2
BK,
minutes,
and
4
that's
seconds.
with experience, all right? And that's with a fairly short residual limb. And sometimes if you have a longer, think of a tibia that's this long, 2 of these guys is not gonna be enough, right? Especially if you got a long femur and a long tibia. Now you're way up here, coming way down here, okay? So if I can have someone re-roll this, actually we're not gonna re-wrap, so we'll leave it. And I'll show you an AK, which is just a little bit different. Your anchor, where do you think your anchor will be? Pelvis. Yep. Okay, so you gotta go up somewhere wide where it's not gonna slip right off of you. All right, so those are done, thank you. Okay, and after I show you all the ACE straps and you can time me and stuff, then I'll show you how easy it is to do 2 of them.
So for the when you just did the wrap, you don't want, like, the distal part was just like an anchor, you don't want to bring the wrap all the way up.
You don't have to. No, you don't have to cover the knee, is that what you're saying?
Yeah.
Yeah, you don't have to cover the knee. I think in this one, the method that's up there, it does show covering the knee. Usually you want to leave the knee uncovered so that when the knee bends, you're not pulling on the ACE wrap, which just makes it unravel more. Plus you can get pressure on the knee pack for bone prominence, so leaving it unraveled is nice. Okay? All right, this is the cushy butt side. So we're gonna roll him over. It's definitely nice to have a second set of hands when you're wrapping, ACE wrapping an AK. Especially if they're old and debilitated, and this leg that should be here, right? Can't do much pushing, because you imagine when I'm going around the pelvis, I'm gonna have to ask the patient to bridge, right? Pick up their butt, lean over, all this kind of movement. Get my third. All right, so we're gonna anchor at the pelvis. Okay, sir, can you bridge up for me? Good.
Went through his pelvis.
All right, so I've got an anchor, all right? Now I'm gonna start my first descending path. And this is the thing that's funny, I'm not gonna go right to the distal residuum with this one. I'm gonna go capture that adductor roll. That's so important to capture. Remember that ugly, ugly adductor roll that you will never forget, okay? Because you don't ever wanna see one of those, that bad especially. We don't wanna capture any genitalia in that wrap. We want to definitely get all of that.
Are you sure about that?
All right, so we're gonna go there. And then on the second one, I came around, get my wrinkles out. On my second one, we'll see if I'm lucky enough to get one distal pass out of this. Not really. Okay, so in that situation where you I ran out of, this is not a good place to tape it. I'd be taping it to skin for one thing, right? So I'm gonna come back up and just give that adductor roll a little extra, kind of going in a spiral fashion here. I say, sir, can you just roll over on your side? And then I would tape him, not clip him. Okay? And then, again, we don't have to anchor now on the second one.
How much tension are you putting around the adductor wall?
Because it's a spiral wrap, you can put a decent amount of tension. I say it's decent, but it's proximal, right? So you always want your pressure to be greater distally than proximally. So I'm just doing this with 50, not even.
25, 30.
So
Pretty-
more,
I mean, look
more
at
than
that.
at the pelvis, less than at the
Yes.
residual.
Yes.
Okay.
Okay, easily I can
The
slip
price
the
is
finger
right.
over there and pull away a bit, but there's definitely some compression. So I'd say light, maybe, light compression. Okay, so this is still my front, yes? Okay. All right, so now you can do this in a variety of ways. The instructions will show you kind of going along with the same way that you were wrapping. I'm gonna go right here where I know there's nothing that little ridge is gonna affect. Okay, so I'm not right at the hip fold where it'll pinch them, just a little bit distal. I'm gonna go ahead and capture, I tape again. My dysfunctional clip. Okay, will you hold this one?
Yeah.
I think it's gonna flip off. And I'm gonna go ahead and come down, capture it at the distal end, pull up some tension. A real limb isn't going to be slippery like duct tape is. Coming up, crossing over this one to start securing it. Come up again to that adductor roll. Capture it. Now I have a pretty nice secure new start. Come down. I have one layer on the lateral. I'm going to come down and capture this big window right here with this next pass. Pull it tight. Come around. I want to get that adductor roll again. You don't have to, but I like it. I've seen adductor rolls and they're a pain in the butt. Come down. Get as much of that lateral edge again. Which if you get too much of this, it can slip right off. So you gotta be careful. Coming now lower. I've got a big old hole right here. Right there. Head's in. Stomach's in. Whatever. All right. So again, I don't want to be attaching right there at the distal end. So I'm going to soften my tension and secure it there. Okay. So let's go ahead and go for. I think you guys get the idea. I would go for another, and then that's where I can start like here, do the nice fishbone or herringbone pattern, which is where you see those crisscrosses right down the center. You know what I'm talking about, right? Okay.
Like a fishtail
Yeah, the
braid.
fishtail.
Okay, herringbone pattern, fishtail. So that is ace wrapping. How long did it take for the AK?
Oh, that was some 4-3.
Okay, all right. So watch this, time this. Now, the thing that takes the most time is getting the tuba grip on the can. And these cans we got from DeKalb Medical's cafeteria. They're industrial size or commercial size green bean cans, tomato sauce cans, and we have them sanitize it. And then it is one can per individual piece. So you don't share cans between rooms. You don't sanitize after one patient and give to another. It is sanitized from the food product, and then it stays with Mr. Jones only. Okay? We put a little note on it usually that says do not throw away for housekeeping. And then the tuba grips, we give 2 tuba grips. You have to measure circumference, that's all up on there on this one slide that I gave you as to measuring what size tuba grip to pick. This is a smaller can, it works for my BK models. The bigger can works for my AK models, so you again have to know your circumferential measure. You slide your tuba grip on, if you'll be my helper again, just keeping the limb there. All right, ready to time? I'm not shearing on my distal residuum at all. I haven't touched the distal residuum, no shearing. I'm going to then take this, and I would be asking my patient to help me here. I'm going to go up to mid-thigh with the top of my tuba grip. So my patient, if you hold right here, I'm going to pull the can down. I'm going to twist it a full 360.
And 2. Left 25 seconds.
30 seconds.
Voila! All right. So, and then of course we pull this up nice. What you don't want, and sometimes this will happen where you didn't turn the can enough and then there's an open hole down there. Okay, so then you just slip, like you've already pushed it on, you see a hole, you pull it back off, twist it more. So generally 360 degrees of twist is enough. And you cut your tuba grip long enough that it is about, you want to be able to go mid-thigh, a little bit of extra, right, to twist, and then it should come up to just below. So you have 2 layers of compression here, 1 layer up here. Okay, so again, more compression distally than proximally. Yes?
I know you said 1 full twist, but when does it become like too much where there's like a knot? Like where's it fixes that?
360 is really enough. You shouldn't have to go more than 360 degree turn. Yeah. So if it helps you to mark something, you know, with where did I start, and I can see that I've made a full 360, that's really just a matter of practice. And if you go more than 360, you might end up with a big knot. Yeah, good question. All right, so preferable, right? Now taking it off, if you